Dr. Sarah Chen is a third-year surgical resident at St. Helena General Hospital, known for her precision, silence, and the peculiar habit of staying in the suture lab until midnight, long after the teaching attendings have gone home. Her colleagues assume it's perfectionism. No one asks deeper questions. The truth is buried deeper. Sarah spent 4 years as a combat trauma surgeon with the 82nd Airborne in Kandahar, performing field amputations and life-saving repairs in forward operating bases where failure meant watching someone die on a stretcher bound for Bagram. She left that world, applied to civilian residency under her full name, and chose anonymity. No mention of deployment, no military credentials on her CV, no stories at resident mixers. She practices military techniques at night because civilian surgery hasn't taught her hands to remember what they knew. The muscle memory matters, the speed, the efficiency, the ability to stabilize hemorrhage with precision when there are no second chances. Then one Tuesday, during a routine vascular repair, her patient begins bleeding catastrophically. In that moment of crisis, Sarah's hands move with a fluency that no 3-year civilian residency could explain. Her attending surgeon sees it. The scrub nurse sees it. And when the bleeding stops, when the patient is stable, when everyone in that operating room takes their first full breath in 3 minutes, the questions begin. What follows is a story about the cost of silence, the burden of carrying classified service into a civilian world that doesn't understand it, and the redemption that comes when duty demands you stop hiding. Chapter 1. The Suture Lab at Midnight. The suture lab at St. Helena General Hospital exists in a pocket of fluorescent emptiness at night. Rows of practice pads lay arranged on metal tables under cold light, each one a pale, synthetic simulacrum of human tissue. The room smells like antiseptic and the faint chemical residue of sterilization. Sarah Chen sits alone at the far table, her shoulders rounded, her hands steady, her focus absolute. It is 11:47 p.m. on a Tuesday. She has been here for 2 hours. The needle passes through the silicone pad with the same resistance as tissue, close enough to matter, different enough to remind her that this is simulation. In the real thing, blood moves. It catches the light. It tells you whether you are fast enough or not. Here, there is only the hiss of the lamp overhead and the soft click of needle through material, thread pulled taut, the knot tied with a precision that most residents would call excessive. Sarah is not most residents. Her attending, Dr. Marcus Webb, has mentioned it casually, almost with approval. Chen, you keep those late hours. Love the commitment. As if commitment is the only reason a surgeon stays after dark, practicing sutures the way soldiers practice drills. As if there isn't a difference between thoroughness and muscle memory searching for its old home. She doesn't correct him. The current knot is military style. 4-handed technique, the kind taught at Kandahar field hospitals, when speed meant the difference between saving a limb and salvaging whatever was left. She ties it without thinking anymore. Her hands do the work. Her mind is somewhere else. A memory of canvas surgical tents, the percussion of incoming mortars, the weight of a soldier's arm going limp. Sarah pulls the thread tight. The knot cinches perfect. She sets down the needle and flexes her hands. There is tension in her shoulders, in the base of her skull, in the small of her back. The tension of someone carrying a classified version of themselves into a world that hired her for a different person. Her phone buzzes. A message from her intern, Kevin. "You at the hospital again. It's almost midnight." She doesn't respond. Kevin means well. He is earnest and young, and he thinks residency is about accumulating hours and gold stars from attendings. He doesn't understand that some of them are running from something. Some of them are trying to remember who they were when the stakes were real. Sarah packs her suture kit. She wraps the practice pads back into their sterile casings. She turns off the lab light and walks through the corridors of St. Helena General at an hour when the hallways belong to the night shift. Nurses moving like ghosts between patient rooms, the hum of machines, the occasional coded announcement that no one registers anymore. She passes the trauma bay, empty at this hour. In Kandahar, there was no this hour. Trauma came on no schedule. A soldier arrived on a stretcher at 0300 or 1600 or in the shower without warning, and you were already moving before your mind caught up to what your hands needed to do. Sarah stops at the vending machine near the resident lounge. She buys black coffee, unsweetened. She sits in the dark lounge for 5 minutes, drinking it cold. Her hands are steady. That is the thing they taught her that civilian residency cannot. Steadiness is not the absence of fear. Steadiness is fear channeled into precision. Steadiness is the knowledge that doubt will cost someone their life. She thinks about the vascular case scheduled for tomorrow morning. Routine, arterial repair, the kind of procedure that should be textbook. The kind that goes wrong when surgeons get complacent, when they forget that inside the body is still blood, still the capacity for catastrophe. Sarah finishes her coffee. She stands. She leaves the lounge and heads toward the resident call room, where she will not sleep, where she will lie in the dark and wait for tomorrow to come and for her hands to remember exactly what they have been practicing alone every night. The suture lab light is still on behind her. She forgot to turn it off. Chapter 2. The patient who should have been routine. The arterial repair is scheduled for 800. Sarah reads the chart at 0630, standing in the pre-op area with her coffee going cold in her hand. The patient is a 63-year-old man named Robert Castellano, admitted with a femoral artery aneurysm discovered during routine ultrasound. The risk factors are textbook. Smoking history, hypertension, age. The repair is textbook too. Dr. Webb will lead. Sarah will assist. Kevin will observe. It should be routine. Sarah has stopped believing in routine. She meets Robert in the pre-op bay. He is small in the hospital gown, diminished by the imminent invasion of medicine. He asks her 3 times if the surgery will hurt. Each time she tells him the truth. He will not feel anything. The anesthesia will take care of that. His body will be the only thing left. "But you'll be careful," he says. Not a question. "Yes," Sarah says. "We'll be careful." She means it with a force that surprises her. She has said variations of this sentence to wounded soldiers, to trauma cases brought in at 0200, to men and women she barely had time to look at before opening them up and racing against exsanguination. The words carry weight she never intended them to carry. Robert is wheeled into the OR at 0745. The room fills with the choreography Sarah knows by heart. Anesthesia setting up their lines, the scrub nurse arranging instruments, the surgical tech checking counts. Dr. Webb strides in with the confident energy of someone who has done this procedure 100 times and trusts that muscle memory will handle the redundancy. Sarah scrubs in at the sink, watching the antimicrobial soap foam across her hands and forearms. In Kandahar, water was a luxury. They scrubbed with betadine when they scrubbed at all, and most of the time they did not have the time. The surgeries happened with hands that were not clean because the alternative to dirty hands was a dead soldier. She cannot quite shake that logic. Even here, the surgical field is exposed. The femoral artery is visible, compromised, the aneurysm palpable under the dissection. Webb makes his incisions with the efficiency of long practice. Sarah feeds him instruments. Kevin watches from the corner, scribbling notes, and she remembers being Kevin, watching, learning, not yet burdened by the knowledge of what can go wrong. Everything is fine for 40 minutes. Then Webb makes a secondary dissection to access the distal end of the vessel, and blood comes, not the controlled ooze of standard surgery. Arterial blood, the kind that moves fast and does not stop easily, the kind that requires speed and hands that understand hemorrhage at a cellular level. Webb curses quietly. "Damn, I nicked the posterior wall." Sarah, retract. I need to see the back of that vessel. She retracts. The field opens. More blood. Her mind does not hesitate. Her hands do not hesitate. In the operating room at St. Helena General, this is a disaster that requires a team and an organized sequence. In the forward surgical site at Kandahar, this is normal. Webb reaches for the 5-0 proline suture. His hands are moving, but they are not moving fast enough. The blood is filling the field too quickly. Kevin is pale in the corner. The anesthesiologist is watching the monitors with increasing tension. 30 more seconds of uncontrolled bleeding, and they lose him. Sarah sees it. Sarah acts. Dr. Webb, may I? It is not how civilians ask. It is how combat surgeons ask. A question that is not really a question. A request that already knows its own answer. Webb looks up. He sees her hands. He sees something in her face that he has never seen before. Not hesitation, but certainty. The kind of certainty that only comes from somewhere else. Go, he says. Chapter 3. The hands, remember Sarah's hands, move with a fluency that belongs to another life. She takes the needle holder. She finds the tear in the posterior arterial wall with a precision that requires no looking. She can feel the integrity of the vessel under the probe, sense where the leak begins. The suture is placed with the economical speed of someone who has done this 1,000 times, whose body has written this repair into its muscle memory so deeply that conscious thought becomes only interference. 1 stitch, 2 stitches. The bleeding slows, the field clears, the artery holds. 45 seconds. That is how long it takes for Sarah's hands to save Robert Castellano's life. 45 seconds of movement so practiced, so efficient, so utterly beyond the scope of a third-year surgical resident that the entire operating room goes very still. Dr. Webb is staring at her. The scrub nurse is staring at her. Kevin has his pen frozen mid-note. The anesthesiologist, who knows blood pressure and cardiac output, but not the specific signatures of military medicine, is staring at her. Status? Sarah asks, her voice level, her hands already moving to tie off the proximal repair. Stable, the anesthesiologist says faintly. Pressure is back to baseline. Webb does not say anything immediately. He watches her hands work through the secondary repair, watches her tie off with knots that are not quite civilian standard, and something in his expression shifts from gratitude to recognition to a question forming silently behind his eyes. The repair continues. Robert's artery holds. His blood pressure normalizes. The crisis resolves into routine again, or what passes for routine after a moment like that. When they close, when the surgery is complete and the drapes are removed and Robert is being wheeled to recovery, Webb turns to Sarah in the OR. That was extraordinary, he says quietly. Lucky, Sarah says. That was not luck. He waits. She does not explain. They strip off their gowns in silence. Kevin is still processing what he saw, replaying it in his mind, trying to match it against the 3 years of Sarah he thought he knew. In the pre-op area, Sarah checks on Robert one more time before he is transferred to recovery. He is breathing steadily. His color is good. He is going to be fine. She thinks about sending a message to someone, an old number, a name she no longer speaks aloud. The impulse is so strong that her fingers almost move to her phone. She stops herself that life is finished. But her hands remember. That is the thing nobody tells you about trauma surgery, about combat medicine, about the specific knowledge that comes from seeing what the human body can endure. Your hands remember. They remember because they have to. Because memory that lives in muscle tissue does not care about decisions you made later. Webb finds her in the hallway. He is freshly scrubbed, his hair damp. "My office," he says, "after your shift." It is not a request. Sarah nods and continues walking, her hands steady, her face neutral, already beginning to construct the story she will tell him. Comment where you're watching from. Let's see how far the stories of real courage and silent sacrifice can travel. Chapter 4. The Reconstruction. Webb's office smells like old coffee and medical journals. The walls are lined with photographs. Webb with attendings at conferences, Webb presenting research, Webb receiving awards. But there is one photo that tells a different story. Webb in younger years, in military dress uniform, standing in front of what looks like a field hospital tent. Sarah sees it the moment she sits down. Webb follows her gaze. 68th Combat Support Hospital, he says quietly. 2003 to 2005, Fallujah mostly. Then I came back, finished my fellowship, and tried very hard to forget what I learned there. He sits across from her, not behind his desk. The gesture is deliberate, equalization, not authority. I know what I saw in that operating room, he continues. I know what I did not teach you. I know what no 3-year civilian residency teaches. So I am going to ask you directly, Dr. Chen. Where did you learn to repair an arterial tear like that? Sarah's mind catalogues her options. Lie, deflect. Claim exceptional training in a fellowship she did not attend. She thinks about Robert Castellano waking up in recovery, about the alternative, a man dying on a table because a surgical resident could not admit to the knowledge her hands possessed. She thinks about the suture lab at midnight. Army, she says, 82nd Airborne, 4 years, 2018 to 2022. I was a trauma surgeon at Forward Operating Base Echo in Kandahar Province. Webb nods slowly. He is not shocked. He suspected. But there is something else in his expression, a kind of recognition that goes deeper than professional respect. Why did you not mention it? He asks. Because, Sarah says, I did not want it to matter. I wanted to be a civilian surgeon. I wanted to learn medicine the way it is taught here, with all the time in the world and none of the blood. I wanted to be someone who did not carry classified debriefings home in her head. And the late nights in the suture lab? Muscle memory was failing, Sarah says. The hands do not forget, but they get confused when they are not used the right way. I was practicing the old technique to keep the old knowledge sharp. I did not know why I was doing it until today. Webb leans back in his chair. He's quiet for a long moment, and Sarah watches him process this. A colleague transformed into something else, someone who was already combat tested, who had already made the life and death calls, who had already paid the price that military medicine demands. You should have told me, Webb says finally, not because it was wrong to hide it, because you needed someone on this team to understand what you carry. And what do I carry? Sarah asks. The same thing I did, Webb says. The knowledge that the stakes are real, that a mistake does not result in a malpractice suit and a review board. It results in someone dying while you are holding the instruments that could have saved them. He stands. He walks to his window, which overlooks the parking lot and the grey November sky beyond it. There will be questions, he says. The scrub nurse saw what you did, Kevin saw. Administration will want a statement. You will have to decide how much of your history you want to make part of this record. And if I do not want to, then you will be hiding again, Webb says, and eventually something will happen that your hands cannot hide. The truth will come out anyway. It always does. Sarah sits with that. The truth will come out. The hands cannot hide forever. The muscle memory writes its own story on the body of the patient, and there is no amount of civilian residency that can erase what combat medicine taught her hands to do. Chapter 5. The investigation begins. The incident report is filed on Wednesday morning. By Wednesday afternoon, Sarah is called into a meeting with the Department of Surgery, the risk management officer, and a hospital attorney named Patricia Okonkwo, who specializes in adverse events and liability mitigation. They review the surgery's timeline. They examine the technical approach. They ask specific questions about her training, her credentials, her authorization to perform the repair. Sarah answers with precision. She does not volunteer information beyond what is asked. She lets the facts speak for themselves. The facts are, she performed a complex arterial repair under the supervision of an attending surgeon with a superior outcome. Robert Castellano is recovering without complications. The alternative, had she not acted, was a catastrophic hemorrhage that would likely have resulted in death or amputation. Patricia Okonkwo leans forward. She is a thin woman with grey-streaked hair and an expression that has been shaped by years of hospital politics. "Dr. Chen," she says carefully, "there is a question that needs to be addressed regarding your military service. Your CV does not list active duty experience." "I did not believe it was relevant to a civilian residency," Sarah says. "It is absolutely relevant," Patricia says. "It is relevant to credentialing, to malpractice coverage, to the hospital's understanding of your qualifications. It is relevant, frankly, to whether you should have been trained to perform this repair at all." Sarah feels the weight of that statement. The suggestion that by hiding her military background, she somehow made herself less qualified, less trustworthy. That the hands that knew how to repair arterial tears in Kandahar are suspect here in Missouri. "I received formal military medical training," Sarah says. "I completed a 4-year trauma surgery fellowship in a combat environment. I performed the repair under direct supervision. Dr. Webb approved the procedure. The patient is well." "That does not address the credentialing question," Patricia says. "The hospital needs to know, did you have proper authorization to perform this specific intervention?" "I did," Sarah says. "An attending surgeon delegated it to me. That is how medical hierarchies work." Patricia makes a note. "We will need documentation of your military training credentials, your discharge papers, your proof of licensure during active duty. We need to verify that you are who you claim to be and that your training is legitimate." The words sting in a way Sarah did not anticipate. That you are who you claim to be. As if there is a question. As if the person sitting in this room, who has spent 3 years working with precision and silence, is somehow not authentic. She provides them with the information. Discharge papers, medical credentials, military ID archived in the digital files of a system that is trying very hard to forget she ever existed. By Thursday, the hospital legal team has verified everything. By Friday, they release a statement confirming that the surgical intervention was appropriate, that Dr. Chen's training and credentials are legitimate, and that no adverse event occurred. But something has shifted. The news travels through the hospital in the way hospital news always travels. The resident who is secretly military, the woman who hid her background, the trauma surgeon practicing sutures at midnight when no one was looking. Kevin asks her directly in the resident lounge, "Why did you not tell us?" Sarah does not have a good answer. Because she wanted to forget. Because the past was classified and heavy, and she did not know how to carry it into a world that was supposed to be better, cleaner, safer. "Because I wanted a second chance," Sarah says finally. "And I was afraid that if anyone knew where I came from, they would never see me any other way." Kevin is quiet. He is too young to understand what that means. The weight of being categorized, of being permanently marked by what you have survived. But he is old enough to recognize that something real just passed between them. Chapter 6. The night the past arrives. Sarah is in the suture lab when the call comes. She is not surprised. She knew this moment would arrive. She has been waiting for it in the way soldiers wait, with acceptance and the knowledge that some things are bigger than personal preference. The voice on the phone belongs to Colonel James Harrison, Chief of Military Medicine at Joint Base Defense in Maryland. The voice is formal, careful, but carries the undertone of someone she has worked with before, someone who was in Kandahar when she was. "Dr. Chen," he says, "we have a situation that requires your expertise." Sarah stops moving. She sets down her needle holder. "I am a civilian now," she says. "You are," Colonel Harrison agrees. "But you are also the only surgeon within 1,000 miles who understands combat trauma the way you do. We have a soldier coming in, transported by helicopter, classified origin, severe thoracic trauma. The civilian hospitals in the network do not have the capability. Your hospital does, and you do." Sarah closes her eyes. She thinks about Robert Castellano. She thinks about the decision to hide. She thinks about the truth that Webb told her. The hands cannot hide forever. "I will need approval from my attending," she says. "Already granted," Colonel Harrison says. "Doctor, Webb has been briefed. The soldier will arrive at St. Helena General's Trauma Center in 40 minutes. The call ends. Sarah sits in the suture lab for 3 minutes. The practice pads remain on the table. The fluorescent light hums overhead, and the past arrives like an inevitability. She gathers her things. She walks toward the trauma bay, where the machinery is already warming, where the team is already assembling, where the thing she thought she had left behind is walking through the door in the body of a soldier she has never met. But her hands know what to do. That is the strange mercy of muscle memory. It does not ask for permission. It does not wait for the mind to catch up. It simply knows, and when the moment arrives, when the stakes are real again, and there is no room for hesitation, the hands remember that they were built for this. If this story has already moved you, hit the like button. It helps more people discover stories of compassion and duty. Chapter 7. The Soldier. The soldier's name is Private Marcus Webb, no relation to Dr. Marcus Webb, though the irony is not lost on anyone. He has been airlifted from a classified forward operation with a shrapnel wound that has collapsed his left lung and fractured his sternum. His blood pressure is unstable. His oxygen saturation is dropping. He has maybe minutes before his body goes into irreversible cascade. Sarah sees him wheeled into the trauma bay, and for a moment she is back in Kandahar, back in a canvas tent with sand on every surface and the distant percussion of incoming fire. Back in the place where hesitation is not an option, where doubt does not matter, where all that exists is the problem and the hands that know how to solve it. Colonel Harrison is in the observation room. She can feel him watching as she dons her gown, as she approaches the table, as she looks down at Private Marcus Webb and sees not a person, but a problem that requires her specific knowledge to survive. Dr. Webb enters the trauma bay. He is going to lead, but they both know that he needs Sarah's expertise here. They both know that this is her case to carry. "Status?" Sarah asks, her voice the calm that comes from having done this before, from having seen the worst and discovered that she can function inside it. The anesthesiologist reports: collapsed left lung, fractured sternum, shrapnel embedded in the thoracic cavity. He is deteriorating. Sarah does not hesitate. She looks at Dr. Webb. "Needle decompression, then thoracotomy?" Webb asks. "Resuscitative thoracotomy," Sarah says. "Bilateral thoracostomies first. We need to decompress both sides. The shrapnel may have gone further than it looks." She moves into position. Her hands take the needle. The first decompression, left anterior chest. The air rushes out. She feels the slight release of pressure, the small victory of having bought seconds for a dying man. Then the right side. More air, more decompression. Private Webb's blood pressure ticks up slightly. His oxygen saturation stabilizes. The moment of crisis passes into critical but survivable. The thoracotomy begins. Sarah's hands crack the ribs with the practiced economy of someone who knows how much force is required. how to minimize trauma while maximizing access. The chest opens, the lung is visible, collapsed and bruised. The shrapnel has embedded itself deep, requiring delicate extraction that cannot be rushed. She works for 40 minutes, removing debris, repairing vessels, ensuring that nothing is left that will create a secondary cascade down the road. Her hands move with the confidence of muscle memory, and through the observation window, Colonel Harrison watches a surgeon who was trained in the hardest school that military medicine offers. When she closes, when the chest is sealed and the drains are placed and Private Webb is breathing on his own with adequate oxygen saturation, the trauma bay goes very quiet. Dr. Webb steps back. He is watching Sarah as she strips off her gloves, as she checks the monitors one final time, as she confirms that the soldier is going to live, because she knew exactly what needed to be done. "You were extraordinary," Webb says quietly. "I was trained," Sarah says. "You were more than that," Webb says. "You were what this soldier needed. You were what we needed. That is what extraordinary is, being exactly the right person in the right moment." Sarah does not argue. She walks out of the trauma bay, leaving the aftermath to the team, and sits alone in the resident lounge as the weight of it hits her. She did not leave the past behind. She carried it inside her, waiting for the moment when it would matter again. And when that moment arrived, when the stakes were real and the difference between life and death came down to hands that knew how to move, she did not hesitate. She was not a civilian surgeon who had military experience. She was a military surgeon who was working in a civilian hospital, waiting to be called back to what she actually was. Chapter 8. The Confession. Private Marcus Webb wakes in the ICU 3 days later, and Sarah is standing at his bedside when his eyes open. He is alive because she knew how to read his body's damage in a language that only combat medicine speaks. He is alive because she did not try to forget what she was taught. He tries to speak. His throat is raw from the ventilator. She gives him a moment. She waits until his eyes focus on her face. "You are going to be okay," she says quietly. "We got the shrapnel out. Your lungs are repairing. You are going to survive this." He manages a small nod. Understanding arrives in his eyes. Recognition that the person standing at his bedside is not just a surgeon, but someone who understands the specific weight of what he has endured. That afternoon, Sarah meets with Colonel Harrison in a small conference room. He is no longer in crisis mode. He is calm, methodical, official. "The Army would like to offer you a reinstatement of commission," he says. "Your old rank, your old position, a position leading the trauma surgery program at Joint Base Defense. The hospital has agreed to a leave of absence. You would be valuable to the program." Sarah listens to the offer. She feels the weight of it, the pull back to a world that makes sense to her, where the stakes are clear and the purpose is unambiguous. She thinks about 4 years of practice. She thinks about the life she built here. She thinks about Robert Castellano and Kevin and Dr. Webb, all of whom have already been transformed by knowing what she is. "I cannot," she says finally. Colonel Harrison does not look surprised. "Why not?" Because I came here to learn to be something other than what I was," Sarah says, "and I have failed at that, but not in the way I thought I was failing. I did not fail because I was not a good enough civilian surgeon. I failed because I was running, and you cannot hide from what your hands know." She pauses. The window of the conference room overlooks the hospital courtyard. It is November. The trees are bare, the sky is grey and heavy with the promise of snow, but I also realized, Sarah continues, that I do not have to choose. I do not have to be purely military or purely civilian. I can be both. I can be a trauma surgeon in a civilian hospital who carries military knowledge inside her, ready when it is needed. I can teach other surgeons what I know. I can take the lessons of Kandahar and bring them here. That is how I serve now, Not by going back, but by staying and transforming the place I promised to be." Colonel Harrison nods slowly. There is a kind of respect in the gesture, the recognition of someone who understands the real cost of duty. "Private Webb wanted me to tell you something," he says. "He said that before you walked into that trauma bay, his father was praying for a miracle, and then you arrived, and he understood what his father meant, that sometimes miracles wear scrubs and have hands that remember." Chapter 9. The quiet after winter comes to St. Helena General. The snow falls on the parking lot and the rooftops, and Sarah returns to her routines with something shifted in her, something settled. She still uses the suture lab at night, but now Kevin joins her sometimes, and she teaches him the military techniques, the speed, the efficiency, the knowledge that comes from understanding that bleeding does not wait for civilian schedules. Robert Castellano comes in for his follow-up appointment 3 months after his surgery. His artery is holding. His recovery is complete. He brings his daughter, who shakes Sarah's hand with a grip that suggests she knows what her father's wife, Maria, told her, that the surgeon who saved his life is someone extraordinary. "Thank you," Robert says simply, "for having the hands and the knowledge to save my life." "You are welcome," Sarah says. "I'm glad I could help." Private Marcus Webb is medically retired. His lungs healed, his sternum fused. He sends Sarah a letter from his hometown in Kentucky, describing the physical therapy he is undergoing, the plans he is making, the fact that he gets to have a future because she knew what to do in the moment when everything was on the edge of being lost. Dr. Webb promotes her to senior resident. He presents her case anonymously as an exemplary response to an intraoperative crisis at a regional surgical conference. Sarah listens to her own story told by someone else, and it sounds like redemption. It sounds like someone who found her way back to her purpose by walking forward instead of backward. The suture lab at midnight becomes something else. It becomes a teaching space. It becomes a place where military veterans who have become civilian surgeons can remember their hands and understand that what they learned is not something to hide, but something to integrate. Kevin brings other residents. Word spreads in the way knowledge always spreads, among those who understand its value. On a night in February, Sarah sits alone in the lab one last time. The practice pads remain. The needle holder sits ready. But her hands do not need to practice alone anymore. Her hands have found their place. Her hands have been acknowledged. Her hands have saved lives by being exactly what they were trained to be. She thinks about the sutures she tied alone every night, the technique she maintained in secret, the knowledge she carried like a burden. She understands now that the burden was not the knowledge. The burden was the hiding. The burden was the separation of the woman who was a combat surgeon from the woman who wanted to be a civilian doctor. The burden was the pretense that these two versions of herself could exist independently. But they cannot exist independently. They are integrated now. They are woven together like the threads in a suture, and the result is someone more capable, more compassionate, more dangerous in the best possible way, dangerous to death, dangerous to hemorrhage, dangerous to anything that threatens the people she is meant to heal. Sarah stands. She turns off the light. She walks out of the suture lab one final time as someone who practices alone. Tomorrow she will teach. Tomorrow her hands will open to receive the knowledge of others. Tomorrow, the military techniques will move from the realm of secrecy into the realm of legacy. Tomorrow, she will stop running and stop hiding and start being the person she was always meant to be. A surgeon who survived war, who chose to heal, who understands that redemption is not about forgetting what you are capable of, but about choosing to use that capacity in service of mercy. Epilogue. We carry our pasts in our hands, in the muscle memory that does not fade, in the knowledge that lives in tissue and bone, in the silence we maintain before we are brave enough to speak. Some of us were made for moments we did not choose, and we spend years trying to become someone else, someone smaller, someone who does not know what we know. But the hands remember. And when the moment comes, when someone's life depends on the exact knowledge you have been hiding, the hands will betray the fiction. The hands will move, the hands will save, and in that moment you will understand that you were never meant to be anyone other than exactly who you are. Subscribe for more stories of courage, healing, and redemption. Thank you for watching the case of the resident who practiced military sutures alone every night. See you in the next one.